Hello, everyone. Welcome to today's webinar. Before we get started with everything that we have in store for you today, we want you to know that we have ASL interpretation uh, for you. If you would like to enable the access to the ASL interpretation, please look on the bottom panel on your computer and just click on interpretation. It will give you the option to open to ASL interpretation. So we're very, very excited and thankful to these beautiful ladies who are doing a marvelous job. Okay, we see that you're coming in. This is exciting. If you would like, you may use the chat function to let us know which country, city, state, part of the universe, right? You are joining from. We are delighted to welcome you to our webinar today titled The Medical Interpreter, a Trauma Nurse Perspective and Expectations. Okay, my name is Analia. I am the manager of training and curriculum here at Cross Cultural Communication, the leading U.S. training agency for medical and community interpreting, and the creator of Blue Horizon, our online learning platform for self-paced and live training programs. I will be your host for today's 1-hour webinar. My beautiful colleague and friend, Naisel Zabala, Administrative Support Assistant at Cross Cultural Communication, will also join us today. Naisel will manage the chat and provide useful information throughout the webinar. Thank you, Naisel. Before we begin, and as we wait for everyone to come online, I would like to share with you our upcoming training workshop in August. Naisel will share the link to, if you would like to register. Please remember that CCC operates in Eastern Time Zone. Okay, brain power and emotional fitness. This two-day course will take place online on August 12th and 14th from 6 to 8 p.m. This workshop is designed to take a quick look at the possible ethical risks linked to interpreters who are emotionally and mentally drained, and provide a set of tips to maintain power of mind and emotional well-being. We hope here at CCC that you can join us. Now, I will go over a few points regarding the webinar. The webinar presentation will last about 40 to 50 minutes, followed by a 15-20 minute Q&A period, during which you can ask our presenter questions. During the webinar, please keep the Q&A feature open and use it to submit your questions for our presenter. For other comments or questions for us here at Cross Cultural Communications, please use the chat feature instead. And if you want everyone to see your comments in the chat, please make sure that you enable it to everyone. Lastly, if you want to stay on after our presenter leaves at the end of the hour to chat with Naisel and me, we will be happy to answer any questions regarding both cross-cultural communications and Blue Horizon. As always, we're happy to say the webinar has been approved for CE use. Please remember that 24 hours after the webinar, attendees will be emailed a link to download a certificate of attendance. It will go to the same email you used to register. Please check your spam or junk folder if you don't see it. Certificates are only available for attendees during the live session of this webinar. Please remember the following. I say please because your certificates must be downloaded within the first 3 weeks of today's session. Do not delay. Do not forget, because we won't be able to send you certificates after 3 weeks from today's webinar. Also, once you download your certificate, save it on your computer, and you will want to add your name in the fillable field. You can also print it if you choose to. Okay, now, without further ado, let's begin our webinar titled the medical interpreter, a trauma nurse perspective and expectation. Let's welcome our presenter Maria Schwieter. She is amazing, and I want to tell you a little bit about it. Welcome, Maria.
Thank you.
Maria has been working in healthcare and medical interpreting fields for over 40 years. Maria was raised in La Paz, Bolivia, and came to the US when she was 20 years old. She holds a bachelor's degree in psychology and nursing and a master's in mental health counseling. Her unique mix of work experience includes trauma nurse specialist, cancer research coordinator, bilingual therapist, medical interpreter, language services coordinator at Beacon and LaPorte hospitals, and medical interpreter trainer. Wow. In the past, she has served as a chair on the National Board of Certified Medical Interpreters, known as NBCMI. Also, she has served as a board member of the National Council on Healthcare Interpreters, NCIHC. Also, she has served at the Midwest Association of Translators and Interpreters, MATI, and she has served at the International Medical Interpreter Association, IMIA. Wow. She said she's a trooper.
Yeah.
Maria is a certified healthcare interpreter through CCHI. Okay, last but not least, one more thing, and I'm going to give her the floor. Maria also developed and she teaches an 80-hour language specific English Spanish course for medical interpreters in which she has included her expertise in the medical field. Maria, we're delighted to have you here today. What an honor, what a pleasure. The floor is yours. Thank you,
Oh,
Maria.
thank you so much for that great introduction. Thank you. Appreciate it. So, hi, everybody. It's great to be here. I was always looking forward to this. And I'll be coming to you as a healthcare provider nurse perspective, not an interpreter per se at this point. So, one of the things that I wanted to bring up is about the emergency department. Um, It's interesting because it's very, very challenging. You don't know what to expect. You could walk in there and just see practically anything. So you really have no expectations of what you might be walking into, like you do in other areas of medicine, like oncology and things, where you kind of have an idea. In the ER, you have no idea. It could be anything. It could be a trauma. It could be a disease, that somebody's like COVID. It could be anything like that. The interesting thing is about nursing is that when we're fresh out of nursing school, we really aren't allowed to work in specialty areas like intensive care or trauma nurse or an emergency department without first having at least a year of working in something like medical surgical floor, where you start to hone the skills that you learned in school. Then you have to take extra training to work in those more specific areas like pediatrics, obstetrics, and things like that. You really do have to have a little bit of extra training for that. So, our assumption as healthcare providers is that the interpreter kind of is in the same place. So, you get out of your training, but in order to go into specialty areas, you might have to have more training. So, you don't walk in there kind of, oh my gosh. Um, so that's just kind of what our perspective is as providers, that the interpreter would have. We kind of expect the same thing out of the interpreter, is that they would have extra training to come into those more specific areas and have more knowledge about it. Um, we have, as providers, we find out that medicine is very complicated, and when you only have 40 hours of training, to us that's very concerning, because there seems to be no clinical time, like practice time. So, as a nurse, we have to do clinicals. We have to go to the hospital and practice what we're learning. And a lot of providers are not sure thinking that maybe that's part of your training, but maybe it's not. So, from our perspective, we would hope that your training would be beyond your 40 hours in order to work in more specific areas because medicine is very complicated, as you all well know, I'm sure. Um, so, I'm going to talk a little bit about trauma specialty. I worked in a level one trauma center, which means all the bad stuff in our area came to our hospital. And so I want to give you a little, I'll do a little PowerPoint, give you a little perspective about what you might expect. One of the things that I found in my training with my students is that a lot of times people aren't prepared for what I call blood and guts. So we had an incident here where I live where an interpreter came out of a training, went to and worked to a hospital. Her first day in the emergency department, there was a girl whose face was ripped off by a dog. And the interpreter freaked out because no one really prepared her for that kind of stuff. And she was so traumatized that she actually left and never came back. So, in my perspective, I want to make sure that my students are prepared for everything. And that's why we're talking about this today. So, if I could have the PowerPoint, please. So, next scene or next slide, sorry. So some of the challenges that we have in the emergency department. So if you could just move up the next slide. Okay. So how do we prepare our interpreters and what happens after the trauma? Those are the things I want to address. Number one, preparing people for what you might encounter. And then when you do encounter, what do we do after that? Because even we as healthcare providers, we also get traumatized. We're human beings. So we have a system where that we can also take care of that. So if you could go to the next slide, please. Okay, so what are the sources of stress? Well, first of all, trauma, and I'm going to show you some gory pictures a little bit later on this, so be prepared. But there's a trauma. And next, difficult patients, somebody who's screaming and cussing at you. Perhaps they're under influence of alcohol or drugs, but they strike out. I've been almost strangled once when I was taking care of a patient because they just out of nowhere just grabbed me. So you got these difficult patients and situations. Next, difficult terminology. There's a whole nother source of terminology that you might encounter. Next. Okay. The other things that you might encounter, which all of these things have happened to me and over the years of working in the emergency department. Child abuse, rape. I'll never forget this one time. Physical and mental abuse. Go ahead. Next. Abandonment. Yeah. And death. Death is a big reality in the emergency department. Interesting story about rape. When I was working as a nurse, we did not have interpreters. This was in the 80s. We violated HIPAA all the time because people would go out in the waiting room and say, somebody here speaks Spanish, and just bring them back and hopefully they'll interpret. We don't do that anymore, thank goodness. But this particular situation was an 11-year-old who was raped, and the 11-year-old spoke English. This was back in the 80s, and the mother did not. So they're using the 11-year-old rape victim as an interpreter for the mother. You can even imagine that. Fortunately, I was working that day as a nurse and I am bilingual, so I went in and kind of took over as a nurse, though I was not a trained interpreter then. Okay, death is a reality. Seen a lot of that in the emergency department, something you have to be really ready for. So next slide. Okay, vicarious trauma. Next. Evisceration, if you know what that word means, it means that your guts are hanging outside of your body, your intestines, basically. Go ahead. Penetrating trauma, things that like a knife wound or somebody fell onto a post. I actually saw that. A person was still awake and the post was stuck all the way through the other side of his body. Go ahead next. These are different things you might encounter. Knife and we call it the knife and gun club, i.e., people knifing and shooting each other. Next, blunt traumas where you hit your head if you fall or fall on your chest and hit your chin. Animal attacks, we do see that occasion, like I told you, the young girl whose face was ripped off by a dog. And burns. Burns are especially challenging. Now, I know a lot of times hospitals will use virtual interpreters, but when you're there in person, the burn is not only visually traumatizing, but so is the smell. And we'll talk about that later. So go ahead. Suicide attempts, seen a lot of those. A lot of those. That's very traumatic for us as healthcare providers. And rape victims, you have to go through the rape kit and the police being there and the whole 9 yards. So you have to deal with that as well. Plus the trauma of actually somebody being raped. Um, Go ahead next. Yeah, I have seen everything. Next. Okay, so there's a example of evisceration. That's actually somebody's liver. We had to send him to surgery. We had to stabilize and send to surgery. So next. And this is the one I talked about the post. The person was still alive, and we actually were able to, well, we sent him to surgery. They were actually able to save him. But interesting to see here, you don't remove that post because if you do, he'll bleed to death. So we actually had to leave that in there until he went to surgery. Next. When the person was awake, so his interpreter would be there. That's evisceration. That's his intestine. Somebody got stabbed in the abdomen, and so the intestine popped out. So next. This actually was a man under the influence of alcohol who passed out with his legs on the train track, and a train ran over him. And I came into work. I was assigned to this patient, and he was still under the influence of alcohol and just sitting there and laughing while his foot was like this. Doesn't even remember what happened. So I'm going, okay, another day. And okay, next. This was a blunt trauma where somebody fell and that was a head injury. Unfortunately, this person did not survive. Um, but you might see something like this. So next. And this is not one of our patients, but um, actually none of these pictures are actually from the people that I took care of because that's a HIPAA issue. But this I got off the internet. But this actually looks like a person that I took care of who was standing in front of a boiler, and the boiler at his workplace blew up, and he was burned from head to toe, second to third degree burns. And he was still awake. His eyes were burned shut, so he couldn't see us, but he could talk to us. And the challenging thing about this is not only the visual part, but the smell. I don't know if any of you have ever smelled burnt flesh before, but it's not pleasant. So what we do is we put masks on with toothpaste or Vicks Vapor Rub or something under our nose so we don't have to smell it. Well, it's very distracting and to do that. So you as an interpreter, part of our healthcare team also would do the same thing that we did to be able to be there. So go ahead next. And these are the things that I train my students so at least they have an idea. And I always tell my students, if you have issues with seeing blood, as an interpreter, you have to be there and you have to interpret, but you don't necessarily have to look. So if it's difficult, you can look down at the floor. The healthcare providers obviously have to work, but you don't. You can look at the floor, whatever, so you don't actually have to look at it, but you still have to be there to be the interpreter. So we have, for those of us at the hospital, I don't know if some hospitals still do this, but in our hospital, we had a critical incident team. So if something happened where we're all traumatized, because we're humans, we do get traumatized as well. We have a system in the hospital where we can go and kind of unload and talk about it and just help ourselves, get over the trauma. Um, so here are some of the things that are critical incidents, like line of duty death, suicide of a colleague. I actually had to take care of a colleague who tried to commit suicide, and that's somebody I worked with. So that's very hard. Go ahead next. Work-related injuries is another really hard one. We've probably all experienced that. Disaster and multi-casualty. We don't think about these things, but if there's a plane crash and you get your emergency department is all of a sudden filled with tons of patients, and they're just coming in right and left in all kinds of different critical stages. It's multi, and you're just overwhelmed. So a lot of hospitals, especially level one trauma centers, have a practice session in case of a disaster. But you as an interpreter will have to be there. As an interpreter, once we had a car crash, and there was 5 people involved. 5 or 6, 2 or 3 died. The other 3 were critically injured, and they were in the emergency room, and it was just like chaos. And but I had to be there as the interpreter. So, eh, okay, go ahead. High degree of threat to personnel. Not lived through that one, but bomb threats and things like that. That's what that's talking about. So go ahead next. Events involving children. Now that's the hardest one of all. Children that have been in car accidents, children who have been bitten by dogs, children who have been abused, which we have to report, by the way, in this state, children who have been raped. These are all very, very difficult things. So these are things that you also have to be able to deal with, and then maybe later on go speak to the chaplain or the critical incident team or whatever, just if you need to. So go ahead next. Um, So events where the victim is known to the personnel, and that includes the interpreter. We had a situation where one of my colleagues was 8 months pregnant, was crossing the street, and the guy couldn't see because the sun was hitting him in the face, didn't see the light and ran through the light and hit her. And they brought her immediately to our ER. She died in our emergency room. And this is somebody I knew. She's a colleague. Those are very, very, and her child died, of course, too. We couldn't save either of them. But that's a very, heartfelt and very difficult. So it could happen to you as an interpreter. It could be somebody you know from your community or whatever. So just as one of the critical incidents that we talk about. So go ahead. Um, Events with excessive media interest. Um, I was involved in one of these as a nurse. A woman murdered her 2 children, a 5-year-old and a 2-year-old. Cut one of their heads off because she had postpartum depression, and those days nobody addressed postpartum depression. So they brought her in the emergency department after the police came, and she was pretty much out of her mind at that point. And so later, she was my patient. I had to take care of her. And later on, I started getting phone calls from reporters. We're not allowed to talk to reporters, but I was getting bombarded because I was involved in this thing that was, made nationwide news. So that's very, it's just very disturbing and made me very nervous because I can't, obviously I couldn't talk to them, but they kept bugging me and bugging me and bugging me, and I had to, keep hanging up on them and stuff. So that's kind of uncomfortable too, but it could happen. It could happen to you as an interpreter as well. So go ahead next. Okay. So that's it. So what I wanted to talk about, there's a lot of questions about recusing yourself. We all have our opinions on, well, I can't take it. Can I just leave? Um, Personally, as a nurse and an interpreter, as a nurse, I can't recuse myself, right? I can't just abandon my post because I can't take it anymore. I don't know if that applies to interpreters as well. I would think so, but that's why we have these webinars to prepare you for things like that, because when you're there, we need you. Just like we need the nurse, we need the interpreter as well. Um, so that's something to bring up with the national organizations. I'm not sure where everybody falls into should we, can we, can't we? I don't know. Interesting topic to discuss, though. Um, so I want to talk a little bit about our perspective as healthcare providers, and this comes from a lot of my colleagues who are doctors and nurses, healthcare providers, techs, etc. What their experiences are with interpreters and what they would like to see. We've had good experiences and bad experiences with interpreters over the spectrum here overall. Um, some of the things that the providers have issues with is they don't feel that the interpreter is interpreting consistently and properly. A lot of and also the customer as well, because a lot of the not all, but a lot of providers maybe understand enough Spanish. This is what I've been. So I understand enough Spanish to know the interpreter was not saying what I said, or there was a sidebar conversation between maybe a patient and a family member, and the interpreter doesn't interpret that, and the providers say, well, so what are they talking about? Oh, nothing, they're just arguing. I had nurse tell me that the other day. So there's things like that that we need to be very careful about, being very professional and following our standards of practice, which says we have to interpret everything that's being said. It's not always happening, according to my colleagues. I had a patient complain to me because she said, I understand enough English to know the interpreter was not saying what I said. So we have to be conscientious that just because we're interpreting doesn't mean that the person we're interpreting for doesn't understand some of the other language. I've also had people say that their interpreters were excellent. So there's this kind of good and bad in our profession. And so my colleagues ask me, what is the standard of training? What, and there is, I don't know because it's all over the map and we really don't have a super standard of training. We have 40 hours, we have 60, we have 80, it's all over the map. So that's one of the things that I can tell you coming from my colleagues as providers perspective. We're hoping that things will become more standard and um, our professionalism will become higher, a higher standard of professionalism. And our expectations are that if you come into something as complicated as medicine, that you will have enough training to be able to do the job, like in the emergency department, for instance. And that would require extra training and extra practice. And also, it's a whole nother culture. A lot of times you go in the office and you stand behind the patient or sit, but in the emergency room, you could be anywhere. I mean, the X-rays coming in, labs coming in, doctors are coming in, surgeons are coming in. You may have to just figure out where the best place to stand is and interpret and get out of the way if you need to, et cetera, et cetera. So it's a whole nother kind of fast pace, not all the time, but a lot of times very fast paced situation. So I'll take questions and answers here in just a minute. But some of the things that I want to talk about is, and technology. We have a lot of technology now. Um, we used to use catheters. Now they have what they call these sheepies, where you just put this, you don't have to insert the catheter, you just put it on top, and then there's a suction machine that will take the urine out so the patient doesn't have to urinate in the bed. So all these kinds of new technologies are up there. So you might want to look into the terminology of that stuff. Um, so I think a lot of my colleagues would prefer that their interpreters be nationally certified at least, um, because we have to be certified as well. So our expectation is that we're certified in this specialty, that so will the interpreter be certified. Um, just a couple of things that have happened to me. So, because I can always talk about things that happened to me, which are a lot, by the way. We had a man come in for the emergency department. Unfortunately, I know my colleagues, everybody would love to have face to face, but that's not possible economically or whatever. So they use a tablet, a virtual interpreter. Um, this just happened recently where we had a man come in and he had what we call a hydrocele. Some of you know what that is. In Spanish, it's hidrocele. Okay, so it's written the same, but it's pronounced completely different. So they had the virtual interpreter live, I mean, virtually. And the patient said, tengo un hidrocele. Okay. And the interpreter did not know what that word meant, which happens. I don't know everything either. So I always have an app that I can look something up. And so she looked it up and then she said to the doctor, he has a drosele. That doesn't mean it's hydrocele in English. And she said he has a drosele, which makes absolutely no sense. So the doctor standing there with this confused look on what? And because I just happened to be there, I kind of whispered, hydrocele. Oh, okay, he says. So then we went through with the interpreter. And then at the end, the doctor says, we're going to give you a medication for the swelling because the hydrocele is a swelling. It's not a bacterial infection, it's a swelling, it's an inflammation. It's nothing to do with bacteria. So the doctor says, we're going to give you some medication. And the interpreter said, we're going to give you an antibiotic, which was completely the wrong thing. It's not an antibiotic, it was an anti inflammatory, but she said antibiotic. Um, and then the doctor said, we're going to make sure to call us if you have swelling in your anus, scrotum, or penis. And she left out the word penis. So so these are mistakes that aren't going to like kill somebody, but they're still mistakes. And it makes me wonder what kind of other mistakes would have been made that actually would cause harm. So this is very concerning to us. One of the things that I think would be useful is to have an app where you look the word up and it shows you how to pronounce it. So because the person looked up the word but did not look up the pronunciation and totally mispronounced it. If I hadn't been there, they would have been a mess because they would have no idea what they're talking about, what she was talking about. So these are kind of the things that our expectations are to be more precise and not make mistakes like say antibiotic for medication because not all medications are antibiotics, et cetera, et cetera. So these are just kind of some of the things that happen. And again, like I say, there's a lot of really, really good interpreters out there as well. We just want to see more consistency. That the problem with us as providers is we don't see consistency. And that's something for us to discuss in the interpreting world, but that's coming from a provider's perspective. There just isn't any consistency. And I've heard this over and over and over again over the years, and still do. Um, so I also want to address something that has come to light is the dual role interpreter. A lot of hospitals, at least in our area, will hire bilingual people, especially for the language that's the highest second language, which in our area happens to be Spanish. And then they will train them. They won't just let them interpret just like that because they're not trained. Medical interpreting is a profession. You cannot do something as a professional without being trained. I think not a good idea, probably against the law for all I know, but so they do have to be trained as interpreters, just like I was. And then they can function as a dual role in their workplace as a provider and an interpreter. There are specific rules for that, or at least we have in place. I don't know if all hospitals do that or healthcare facilities, but the dual roles main job is being the provider. So that's their main job. That job comes first. As an interpreter, they can be used as an interpreter in their place of work. They cannot be removed from their unit because the unit is their main job. So they can function as both. Also required national certification. I don't know that many states require national certification, but I would highly recommend it. Um, so let's see, what other challenges do we have here? Like I said, you have to be prepared for a lot of things. You can never know what you're walking into in the emergency department. And so, any questions before I go on?
Hi, Maria. I think there may be some questions in the Q&A. So let's look at we have any specific questions for you.
I know there's one about can I recuse myself?
Okay.
Again, we have to address that nationally. That's not up to me, but
Yes, the recusant.
personally, yeah.
Go ahead. Go ahead.
Well, because I think to myself, this comes up in nursing too. So maybe your father was an alcoholic, okay, and abused you and blah, blah, blah. Now you're a nurse, and now you get this person who's under the influence of alcohol or an alcoholic basically, and comes in and you get emotional about it because this is a very, you've lived through that and you're emotional and it's hard. right? To take care of someone in that state of mind. But the big but is I can't not decide who I want to take care of and who I don't want to take
Hmm.
care of. I can't, it's not. I got into this job, I know what I'm getting into, and I just have to deal with it, do my job, and then deal with the emotions later. And I think that probably would hold true for interpreters as well, because you are part of the healthcare team. And believe me, we really appreciate you as being part of our healthcare team, but we also have the same kind of ethics, that we have to follow. So that's an interesting, that's come up a lot. I've had people ask me that a lot. I was like, well, you take this job, this is your job. And if
Yes,
you
and
don't
I
like it, then don't, yeah,
right, exactly. And I would like to share with you, with the audience as well. When we are applying for a job, right? We also ask questions. What kind of encounters may I be
right,
interpreting for? And that's an opportunity for us as interpreters to decide, well, I may not do well in these type of encounters,
right,
right? And therefore, we should not take that job because it is unprofessional
right,
to
right,
choose what
right.
we want to interpret for and what we don't want to interpret for. So if we, and we, let's everybody remember, we're representing the profession. So
Mhm.
this is our time as interpreters to find out what the encounters may be like, what kind of scenarios, and then if it's something that we don't feel comfortable with, it is okay. That's why there are different type of interpreting encounters
Correct,
and agencies that we can work for. Like
correct.
I used to work in labor and delivery, and I knew what I was coming into, and I loved it.
Mhm.
I loved it. Not everybody's going to enjoy labor and delivery. Then don't work at a hospital for labor and delivery, right?
Well, and the other thing is, I'm glad you brought that up because you're right. You can work for a clinic, a pain clinic, and that's it. So you go, I can't deal with trauma, so I'm not going to do that. But if you work in a hospital, you have to be super diverse because, like, I worked in the hospital. I had to go everywhere. I had to go to pediatrics. I had to go to labor and delivery. I had to go to the emergency department. So if you're actually working for a hospital, you have to be able to be that diverse. And I'll tell you, I learned more about the nursing profession as an interpreter because I had to go everywhere in the hospital.
Right,
So that working in a hospital that has a lot of units, that's the biggest challenge of all because you have to be super diverse. But you're right. If you can't deal with that, then work in a clinic or work for a doctor's office or an agency, like you said, where you can pick and choose your jobs. So absolutely
right.
right.
And somebody just posted on the chat, well, with an agency, you don't know what type of assignment you're going to get. Maybe not every single type of assignment, but they will give you a general
Yep.
idea
Yeah, they
of
will.
what you can expect. And that's where we should decide this is not the area that I
Right,
would like to interpret
right.
for. Maria, there was a question here, and I think what would you recommend for us? Somebody typed, I would like to know what resources or training RNs have to face these kinds of traumatic situations? Are there classes that they take, or do they just become desensitized over time?
Now, for you mean for specialty units?
It is just talking about, I guess, what the trauma, working in the
Okay,
ER.
well, in order to work in the trauma center, I had to go to, I think it was 3 weeks of training for trauma as a nurse,
Mhm.
and the hospital provided that training. Now, that was years ago. I'm not sure what they do now. I'm sure they still do that. You have to do some clinicals, shadowing, whatever. Yeah, but you can't just walk into something as complicated as a trauma center fresh out of school because you're fresh out of school. The practice is what makes you good, right? But you have to be able to use what you've learned. What really, I guess one of our kind of big concerns is that a lot of interpreting courses, I don't know what the percentage is, do not have practice.
Mm.
And
Mhm.
that, at least to me, practicing is the most important thing there is because, yeah, you can sit there and book learn all you want, but if you don't use it, you don't know how to use it, you're not critiqued on how you're using it. You're out there in the world, who knows? That's one of our big concerns is clinical time. It doesn't exist in a lot of, not all, but a lot of courses, and we feel that there should at least be some of that, some shadowing,
Mhm.
something. where you actually use what you learned before you actually go into the field. Again, we're so grateful that we even have training now where we didn't before. Like I say, in the 80s. Oh, here's another. In the 80s, we had a housekeeper at the hospital in the ER who was from Mexico, I believe. Her English wasn't very good, but she understood some. So they had a woman come in with abdominal pain, and we had no interpreters, and I was with another patient, so they took the housekeeper in to interpret for this woman, and the housekeeper totally blew it and said, "Oh, she has a bladder infection. It's her
Mm.
bladder that hurts," which actually she was having a miscarriage.
Oh,
Yeah.
no.
So these are the kinds of stories, thank goodness that we have what we have. I know we still have to evolve and get better, but
Hmm.
it's so much fun.
Wow.
Yeah, yeah, I'll never forget that. Wow. Like, how do you mistake a bladder for a uterus?
Eh, the egregious mistake for sure. Let's see if what other questions we have. It says, what would you recommend as proper procedure when we have a traumatic encounter? Where I work, I just have to go to my next appointment, and I find it extremely draining.
What do you do? Well, again, it depends. You're working for somebody, you have back-to-back appointments, or is this?
Um, I don't know that this is the
Yeah.
question. It's
Uh,
basically what would you recommend as a proper procedure when we have a traumatic encounter? Where I work, I just have to go to my next appointment, and I find it extremely draining.
Training.
So, yeah.
Boy, that's a whole nother webinar right there. I think there is one coming up for that, as a matter of fact, right? About what
Yes.
to do when it's draining. Well, sometimes you just have to keep going. Like we work 12-hour shifts in the emergency department. That's 12 hours of nonstop, especially in a level one trauma center. So you just do what you have to do, and then when it's over, then I know it's draining. It's horribly draining. Um, then you just have to go with whatever works for you as far as calming down. Usually what I would do is I'd go talk to the chaplain because he's right there.
Hmm.
He, she is.
Right.
And that would help a lot. I just need to talk, and there they are. So, but everybody has their own way of dealing with stress, which in your upcoming webinar, hopefully will give a lot of ideas about that. The other thing is you just steel yourself. I had a situation in the emergency department. This is the only time in my life, in my career as a nurse, that I actually went home and threw up from stress. But it happened
Hmm.
after I got home. I had to deal with my job, and that's what I have to do.
Right.
But what happened was it was a family who they were from China, and they were driving recklessly for I don't know why. But anyway, the grandmother was sitting in the front passenger seat with a 6-month-old baby in her arms, no seatbelt
Mm.
and no baby carriage, whatever. So she's sitting in the front with this 6-month-old in her lap, no seatbelt. Father was driving like a nutball, two teenagers in back. And I believe the way, anyway, he hit a tree, I don't know at what speed. And everybody was killed except the 16-year-old daughter. Everybody else died. The
Oh.
baby went through the windshield. The 6-month-old went through the windshield and it decapitated the child, but the head was hanging on by a piece of skin.
Mm.
So normally you don't bring deceased people into the emergency department, but what happened was the paramedic who was on the scene, had a child the same age and he freaked out.
Mm.
So he picked up the child's body and started screaming and crying and wouldn't let go. So they brought the
Mm.
paramedic with the child in his arms into the
Hmm.
emergency department. And we had to,
Hmm.
and so that's how we wound up witnessing this, you know, um, that affected all of us. Everybody in that who was on duty that day was very, very affected. And so we, went to the stress, critical incident stress team. We went to the chaplain. We just did what we had to, um, and then dealt with it. And I tell people these things because as an interpreter, it could, and not necessarily will, because if you're
Hmm.
working, but it could happen to you. And these are the things that you just need to deal with. Like I say, the chaplains are always there, or you're uh, meditating, whatever. I can't wait to see your webinar, see all your different things that you
Yes.
do.
Thank you, Maria. I do want to say to everybody today at the webinar, I mean, these are stories, right? True stories that are completely devastating. They are horrific, unimaginable. I will tell you, I've worked for different companies, and most companies, I cannot say every company, but most companies, as an interpreter, they offer the employee assistant program.
Yes,
I
yes,
would say most companies do,
but not all. Yeah.
not all. And what that does is that you get like free so many 4 to 6 sessions for free where you can meet somebody and debrief this type of
Yes.
encounters, obviously protecting all confidential information. Just talk about what the encounter was about and what how it is affecting you,
Mhm.
because we're human beings.
Yep. Yep.
For us as interpreters, I highly suggest that when you have an interview, don't think about the interview just as the person interviewing you. You interview them as
Yes.
well. You go ready and prepare as a professional with your questions. What kind of encounters will I be interpreting for? Does your organization adhere to a code of ethics, whether it's for healthcare, for social services, or for education? What kind of do you offer any program for interpreters when they interpret for difficult encounters, for them
Right.
to be to have get some counseling and assistance? So everyone here, thank you for being here today. This is an open space to say we need to help each other, right,
Right.
as a profession, and prepare yourself for those kind of questions to ask the organization. Yes, Maria, I'm sorry,
Yeah,
I just kind of like.
I got a couple. There was something in the chat about talking to police. Let me tell you about my experience with talking to police officers. And what I do is, if the police officer comes in to question the patient who has to do with police business, let them bring their own. You don't work for them, number one. And this is what happened to me because I was too naive. So they came in, somebody was assaulted, and so the police are interviewing the patient on who assaulted you, blah blah blah, and I'm interpreting, the Miranda, whatever. No, I don't even know that in Spanish, but anyway, um, guess what happened? I got called to court. Yep,
Wow.
I got called to court for interpreting for the police officers. They go, "Well, the interpreter." So I'm sitting there, not very comfortable because I'm not a legal interpreter. I've never been to court. So anyway, was it the defendant, the guy that was defending the guy that attacked the patient was trying his best to prove that I didn't speak Spanish that well because obviously I look like a gringa. So he was trying his best to prove that my Spanish wasn't good enough and that was my fault and I misinterpreted, and misrepresented and blah blah blah. It turns out I was able to prove I'm bilingual, but it was very uncomfortable. So I tell my students, no, that's not your job to interpret for the police. Your job is to interpret for your agency or the hospital, whoever hired,
Right.
and they're separado. Um, they're
I
separate.
love it. Separate the people, separate. I love it.
So the other thing I wanted to say, I really, really want to say this, and hopefully we'll all get together on this, is that providers and interpreters need to come more together.
Hmm.
While there, I was going to nursing conferences like the American Association of Nurses and stuff, because I'm a nurse, so I can go to these, and presenting the interpreter's point of view and what we are and what we do and why we're an integral part of the healthcare team. To get that togetherness, we need to really do more of that. I'm very, very adamant about us and providers both coming together at our conferences and talking to each other, and we are part of the healthcare team, so therefore we should just communicate as part of the healthcare team. And a lot of providers don't understand our job, don't, you know. So I think that to me that's very important. So if any of you, yeah, I'm kind of getting older and harder to do, but if any of you are really interested in doing stuff like that, I would go into try to apply for being a speaker at providers conferences, mental health, hospital association, nurses associations, and go be speakers and talk and communicate. And I always try to get providers to come to ours as well as speakers and and kind of get together and do our thing. I have a lot of physicians and nurses come to my class as guest speakers so they can see both sides. both sides can see both sides. That kind of makes sense. I don't know.
Maria, that is an excellent suggestion. And I'm so glad we have over 800 attendees right now because what Maria, excuse me, just shared for each one of us is that we make a difference. We're agents for change. So
Yes,
volunteer your time and say,
yes,
hey, I'll come and I'll speak about what we do as interpreters. Because if you want people to value what we do, we need to educate them. That's part of the process. So, yes, thank you, Maria. That is an wonderful suggestion. And before I forget, one more thing. Again, if you're not working for the police, you don't need to interpret for them.
that's
And
what I think.
yes, and the next thing that I wanted to mention, since we're talking about this topic, please remember if you have any clinician or somebody asking you to sign as a witness, remember that you can kindly say that you are there as the interpreter,
Right.
that you will create a line and you write interpreter, and yes, sign your name as the interpreter
Mhm.
because we are not clinicians, right? We're not educators if you're working at the school system. So you're not signing. We should never sign as a
Oh,
witness
right,
because
right.
they can call you to court because you
Yep.
were a witness.
Yep.
And remember that we interpreters use or employ short term memory, right?
Mhm.
So we don't have recollection of what happened a month ago because we're using our
Right.
short term memory. And remember, if you're taking notes, you're shredding those notes, right?
Yes.
So you don't
Yep.
have anything else to look at. So again, protect yourself. Be careful, right?
Mhm. Yep. Yep. All good point. All these come from life experiences. Everything I teach in my class come from all my experiences of being a nurse and all the stories. I have my students go, I've had students call me years later and going, we're in this situation and I remember the story. And that's what gave
Yep.
me the what I'm supposed to do. It cracks me up.
I call them horror stories,
It is
right?
horror stories. But it's that personal experience that's so helpful to students because they're not just making things up, right? This is the
Right.
real world out there. Yeah.
Yeah. Maria, somebody has a question here for
Yeah.
you, and it was a while ago. And I'm so sorry that we didn't see this question. It says, Maria, with all due respect, has it ever happened that you find that the provider or patient believe they know more of the target language than they actually do and misjudge the interpreter saying they didn't interpret accurately?
That correct. You're absolutely right. Thank you for bringing that up. You're absolutely right. Just because they say that doesn't mean it's true.
Hmm.
I just hear it a lot, but you're right. It could be just an exaggeration. Yeah. So it's hard to tell. It's hard to know. Um, I don't know what to tell you. I'm just passing on what they're telling me. So yeah, I think the biggest one is when there's like a side conversation or argument and the interpreter
Mm,
doesn't. That's obvious, not what happened. But as far as the language. Yeah, I'm just passing it on.
yes. Here's another question for you, Maria, because you are a trainer as well. It says, how do you prepare your students for these situations that are very extreme?
Well, we talk about it a lot, and I can bring my own emotional part of it because I actually lived through it, and sometimes I show gory pictures. But you
Yeah.
can only prepare so much. What we used to do back when I was teaching face to face, I don't anymore. I'm online now because COVID came and I see this. But when I used to teach face to face here in my community, I would get those old vampire blood, from Halloween, and we would do
Mm,
what we call moulage, where I'd squirt it on somebody's face so it actually looked like somebody
yes.
was traumatized, and then the students would have to go and be interpreters. But that yeah, but anyway, it's just basically talking about it, showing pictures, and then, so at least have an idea, be prepared. Because you could say, "Oh, yeah, there's blood and guts," but when you actually see a picture of it, then you can kind of visualize, this is what
Hmm.
in real life. I'm a big believer in that, especially after that incident where this interpreter freaked out in the emergency room and left her profession after 1 week because nobody prepared her for it.
Hmm.
Yeah.
Exactly. And also, as interpreters, Again, there is no way we can be prepared for everything.
Everything.
Let's be
Not even as a
realistic.
nurse, you can be prepared
Yes,
for everything.
and it's one of those things that I guess something else. Bes- Hopefully, if the agency has an employee assistance program, you can debrief
Yeah.
without sharing any information with supervisors, with managers, even with colleagues, and you can ask them. I mean, there are so many strategies as far as, yes, you go for a walk, debrief, but I know what we're saying about we need to get more training into how handle those type of situations.
We need consistency in our training. That's
Mhm.
all over the map, and that's kind of how nursing profession started years ago. But we need to move ahead. We really do. We're just people are going, what? There's no accreditation. There's no consistency. Everybody does what they want, and so that's a lot of times that's concerning because it's hard to pinpoint down. I know this is a progression, like any profession. It's a progression, just like nursing progressed. It took decades, but we did, and I think we as interpreters will progress as well because we want to. We will. It'll just
Mar-
takes time.
yes, Maria, I saw just quickly on the chat a question about, do you have any recommendations for medical terminology apps or websites that you recommend?
I think Lingui is one that's widely used. Lingui, I don't know how to say.
Yes,
You're
I
familiar with
mentioned
that?
that earlier, but do you have any other ones
Uh-uh.
that are more related to medical terminology?
Not that I know of, no. So, but if anybody does, please post it.
Yes, put it on the chat. Put it on the chat if everybody has a. Okay, yes, we talk about word reference, lingui. Okay, let's see if we find any other questions.
I would like to have one that has actually tells you how to pronounce the word because after that
Mm-hmm.
one incident, I thought, yeah, you see it, but you have to, understand pronunciations are different in different languages. Yeah. Now, that was an eye opener for me. That I said, wait a minute.
Okay, here's a question. How can providers and interpreters collaborate more to better care for LEP patients? One thing we try to do with our inpatient team is have the interpreter join the care team for any pre-encounter conversations, meetings, to learn about what the conversation might look like, terms that will come up that we need to make sure we can interpret accurately, etc. Any other thoughts?
Well, at our hospital, they have orientation for new employees, and the interpreter language access was part of the orientation. And the other thing is, we used to attend doctors. We could have luncheons. Get all these luncheons and
Mhm,
get people to know you because then when you're eating, you're relaxed, talk to each other. The other thing is we had skill validations every year for the nurses in our
mhm.
hospital. Every year they had to go through the stations. We did the exact same thing for the interpreters as well. And then we would have about a couple of times a year conferences, general conferences where the interpreters were, as well as the providers were all involved. Usually it's just the providers sitting there, but the interpreters were also became part of that. So those are just little suggestions. I don't know what other facilities do about that, but again, it's up to us to also try to
Yes,
promote to that, not just wait for them. We should all be this together. So we should be the ones out there promoting as well.
absolutely. And this is where our pre-session or formal introduction with the provider, we can let them know, could you please tell me what the encounter is going to be about if there is a moment, right? What kind of medical issues is the client having, etc. Okay, before I forget, it's 12:31. If people need to be dismissed because you got to go back to work to interpret, etc., the webinar is formally over. And again, I do want to remind everybody, 24 hours from now, you will receive a link to the same email that you got registered for this webinar with instructions to download your certificate. Please remember, because this happened to me and I know it has happened to people, to fill out your name on the certificate when you submit it for CE use. If you submit it and it doesn't have your name, it won't work. So please remember to fill it out with your name, last name. There was a question on the chat. whether there are CEUs for MBCMI, IMIA. They are pending. We requested them. They are pending. So hopefully they'll be approved at some point. So I saw that question on the chat. Anything else, Maria? Any other question that you saw that I have not brought up?
Um, it says, resources for training RNs to face these kind of traumatic situations. Are there classes they take or they become desensitized over time? That's very individual. You do kind of become desensitized, but no, but you're human and you're never completely desensitized. So this is interesting. How can we increase requirements in state like Minnesota, where there are no regulations besides the 40-hour initial training? Um, this is something that's near and dear to my heart is training, and
Mhm,
40 hours is I can't imagine anybody thinking that 40 hours is good enough for anything, especially something like medicine. And so we, in our community, we as interpreters have been really getting out there and fighting for upping our standards as professionals.
mhm.
I've spoken to several CHIA conferences about this and et cetera. It's just up to us. It's really up to us because nobody's going to do it for us. So, just like in my community here where I live now, people, nobody knew about Title VI, or they did, they ignored it, whatever. And we're still using family members, even though it's against the law. We did have trained interpreters in the state. It was up to us interpreters to go out there and really fight. And
Mhm.
what we did is we educated our community. We didn't go fight with the providers, but we educated our community. That was the key right there. We spent a huge effort. We were on the Spanish speaking radio station. We handed out pamphlets. We went every neighborhood telling people what their rights were because people don't know.
Mhm. People don't know.
Our community found out what their rights were, and they would even have a little uh, card that would say, under Title VI, you have to provide me an interpreter. And they would hand that into the
Right,
And
right.
they're compliant. Everybody in our whole this part of the state is compliant because of our efforts. Just something I'm just saying out there, go out there and, educate people for their rights, be part of this whole essence of change and making things better. Yeah.
Right. And again, when there was a question about we need higher wages as interpreters.
Oh,
We
yeah.
really, really do. And I will tell you, I got my CCHI certification in 2015. And at the time where I was working at, they didn't give me a raise. But you
Mm.
know what? I did it for myself because I am a professional and
Yeah,
I wanted to learn. And so I highly encourage you, continue to educate yourself, aim higher, be professional, inform others like Maria has been suggesting, go to places. And yes, we do need to interpret, and sometimes that is what we do for living. So definitely keep doing a great job. If you do that, people will take notice of you. And lastly, when you can, offer, be a volunteer because you never know how you volunteering, number one, because it's the right thing to do if you can volunteer your services. People will hear, hey, there was a great interpreter that volunteered their time at such clinic, and you may have people call you to actually, pay for your services. But I do believe what we do when we also serve the profession, like doctors and nurses do, and physical therapists, people see, hey, there are interpreters also willing to donate their time to those places that everybody's donating their time because guess what? There is no money. But we're here also for the people. So, yes, get a place where you get compensated for the work that you do, but also look for times where you can donate your time. I just did that last weekend at an organization, and it is very fulfilling to do that because we are professional people in the healthcare profession, and donating our time also says a lot about who we are.
Yes. Okay, Analia, thank you so much for having me. I really appreciate it. Talk to
Yes,
people.
Maria needs to
Thank you so
go.
much,
It's
everybody.
past the time.
I need to go pick up my husband from the hospital. So
Okay, Maria, thank you so much. We really appreciate you. We'll be in touch, Maria. Have a wonderful day.
too.
Thank you.
Thanks. Bye.
Thank you. And for everyone, again, the webinar was formally over at 12:30. I see we still have over 500 people here at CCC. We really advocate for the profession. We are for the profession. Thank you for joining us because now you go out and you represent the profession and you are impacting people that we at CCC we can't because we're not out there. For everybody joining us from the United States, thank you so much for being here. We want to acknowledge that we had people from Australia, Canada, Mexico, Argentina, England, Costa Rica. If I missed your side of the world, I am so sorry. I couldn't keep up with everyone, but thank you so much for joining us. Have a wonderful, fantastic rest of your day and your week. And again, I will remind everybody that in 24 hours from 12:30, when the webinar was over, you will receive a link guiding you to download your certificate of attendance. Please make sure you fill your name in the fillable part, save it in your computer, okay, and then submit it for your CEs. Okay, don't wait till the last moment to do that. And again, thank you so much, everybody. It's a privilege to be here to serve you. I want to say thank you to Nicel. Nicel joined CCC about a year ago, and I will tell you, Nicel is my right hand. And I always tell her, you're my left hand, my right leg, my left leg. A lot of what happened behind the scenes at CCC is because of Nicel. So I just want you to know that. She's new here joining us at the webinar, and I just want to say thank you to Nicel because she does so much that we couldn't function without what she does. Okay, I don't see any other questions regarding Nicel, you got a round of applause. Awesome, awesome. Okay, everyone, thank you so much for joining us. We'll see you at the webinar in August, right? And we have Marisa, Reda Will, Tika from Tika, the interpreter. She's going to deliver that webinar. It's going to be fantastic. I am going to also, let's see, put on our chat our website so that people can look to any information that you may have, questions about CCC, etc. But everyone, thank you so much. Thank you to the gorgeous ASL interpreters, Olivia and Victoria. They did a fantastic, phenomenal job. We are going to be providing ASL interpreters. Please share with everybody. The webinars are free for you. I will say for ASL interpretation, there is a $20 fee, but that will be to just email us at solutions. If you're an ASL interpreter, Nicel, can you post where they should send if they have a questions, where to request for an RID, a certificate CEUs? So for ASL interpreters, there is a fee, but it's not a fee that CCC is charging you. It's a fee from RID, and it's $20, just to let you know. $20 to process. Thank you, Nicel. She already posted it. So it's a fee that RID will request, and it's $20, but everything else is, for free. Okay, everybody, I'm going to close the webinar. Have a wonderful day, and we'll see you in August. Thank you, everybody. Bye.